Good afternoon, esteemed colleagues. I am Dr. Jadine Frank, a third-year resident in the Emergency Medicine program at the University Hospital of the West Indies, Mona campus. It is with great pleasure that I welcome you all to our third Emergency Medicine Grand Rounds for the year 2026. Grand Rounds serve as our academic heartbeat, where we are able to knock down the walls of medicine as we share knowledge and foster a community. Our topic for this afternoon is the second wave after Hurricane Melissa, focusing on the post-hurricane burden of medical, traumatic, and psychological diseases. We are pleased to host this forum, and as we gather here, we take this valuable opportunity to step away from our busy daily schedules to share clinical knowledge, discuss challenging cases, and review the latest evidence-based practices. Our aim today is to engage in a comprehensive trans-departmental discussion that translates directly to improved patient care. Let us make this an opportunity to learn from each other and bridge academic theory with practical application. Before we begin, let us pray. Almighty God, thank you for the privilege this afternoon to have this grand rounds. We ask that you will guide the proceedings. Please grant wisdom to our presenters and understanding to all our attendees. Please guide the discussion that it may help us to better care for our patients, not only in expertise, but also in compassion and with humility. We pray that this will be a productive session in your holy name. Amen. At this time, we will have the introduction of our first speaker by Dr. Kamala Barrett.
Good afternoon, everyone. My name is Dr. Kamala Barrett, and I'll be introducing the first presenter. Dr. Williams is a first-year emergency medicine resident at the University Hospital of the West Indies. She completed her medical training at the University of the West Indies, Mona, where she developed a strong foundation in clinical medicine and a keen interest in acute care. She is currently building her expertise in the fast-paced environment of emergency medicine, with a focus on delivering timely, high-quality care to patients in critical settings. Today, she will be presenting a series of 4 clinical cases highlighting hurricane-related pathologies and complications observed in the aftermath of Hurricane Melissa, with an emphasis on emergency department presentation and management. Please join me in welcoming Dr. Williams.
Good evening, everyone. I will be presenting the cases. We will start with case 1. So case 1 is of a 43-year-old male. The presenting complaint was a tree fell on the patient the evening prior to presentation. The patient has no chronic illnesses, presented a day after a tree fell on him as he stood outside of his home. He reported neck pain and limb weakness with associated difficulty moving all limbs. He denied loss of consciousness or ENT bleed, denied abdominal pain or chest pain. He then presented to the emergency department by relatives 24 hours later because roads were blocked to his community, hence the delay in his presentation. In terms of his past medical history, past surgical history, and drug history, they were nil contributory, and he reported no known drug allergies. He smokes cigarettes and marijuana occasionally and admits to ingesting alcohol prior to incident. In terms of the physical examination, his vital signs were as follows. The temperature was 97.2 Fahrenheit. The pulse was 50 beats per minute. Respiratory rate of 18 breaths per minute. Blood pressure 101/54. And the saturation was 93 to 95% on room air. There was an adult male in no obvious cardiopulmonary distress. Mucous membranes were pink and moist, anictoric, acyanotic, and afebrile. The cardiovascular, respiratory, and abdominal exam were negative for any abnormalities. There was decrease in anal sphincter tone on digital rectal exam, and no wounds were noted on the musculoskeletal exam. In terms of the central nervous system, he was awake, alert, oriented to time, place, and person. His GCS score was 15 out of 15. Pupils were equal and reactive to light at 2 millimeters. He had normal bulk and tone, a power of 1 out of 5 throughout all limbs. He had a sensory level at T4. The bulbocavernosus reflex was absent. There was C-spine tenderness at C4 level, no lumbar spine tenderness, and no tenderness to the anterior and posterior chest wall. In terms of the investigations, the C-spine X-ray showed a fracture to the C4 spinous process, anterior displacement, and loss of lordosis. The chest and pelvic X-ray was normal, and the ECG showed a sinus bradycardia with a rate of 58. The MRI spine showed C4, C5 anterior listhesis with fracture of the C4 spinous process. So on assessment, there was a C4, C5 anterior listhesis with fracture of the C4 spinous process, high cervical spine injury at C4 with an Asia classification of C, C4 sensory level, and neurogenic shock. In terms of the plan, a C-collar was placed. He was given 2 large bore IV accesses and blood investigations were taken off. He was administered Baralgene 1 gram IV, given IV fluid hydration with normal saline. A urinary catheter was placed. The ECG was repeated, and he was admitted to general surgery and neurosurgery. And now we will discuss case 2. Case 2 is of a 57-year-old male. The presenting complaint was generalized weakness for 8 days, yellowing of the eyes, and dark urine for 4 days. In terms of the history of presenting complaint, the patient presented with an 8-day history of generalized weakness and frontal headache associated with retroorbital pain and photophobia. He had reduced appetite, nausea, and 2 episodes of vomiting. He also had a 7-day history of fever with chills and rigors with a Tmax of 38.9 degrees Celsius, and a 4-day history of jaundice, yellow stool, and dark urine. He denied coughing, vomiting up blood, no melena, and no bright red blood per rectum. In terms of the relevant exposure history, he works as a food outlet in Old Harbor, and ever since Hurricane Melissa, there have been reports of rat infestation at the workplace. Multiple co-workers recently diagnosed with leptospirosis. For the past medical and surgical history, he has benign prostatic hypertrophy, A prostate biopsy was performed 9 days prior to presentation due to urinary symptoms. He doesn't smoke or drink alcohol, and he has no known drug allergies. Now his vitals on presentation, his heart rate was 102 beats per minute, respiratory rate of 24 breaths per minute, a temperature of 36 degrees Celsius, blood pressure of 147/92, oxygen saturation of 88% on room air, and his glucose was 8 millimoles per liter. On general examination, there was a male patient in mild respiratory distress receiving 15 liters oxygen via face mask with a non-rebreather. He was icteric, acyanotic, and afebrile. His mucous membranes were pink and moist. Cardiovascular system, his pulse was regular. Apex beat was in the 5th left intercostal space, mid-clavicular line. He had a normal S1 and S2. No S3 and S4 or murmurs were heard. He, however, had mild pedal edema up to the knees bilaterally. On the respiratory exam, he had decreased breath sounds and crepitations in the mid-lower zone on the right. His abdomen was soft, distended. He had right upper quadrant and epigastric tenderness, no guarding or rebound tenderness. His liver span was 13 centimeters, but there was no splenomegaly and the kidneys were not ballotable. His bowel sounds were also heard. On digital rectal exam, he had an enlarged prostate, but no masses, no PR bleeding, and there was brown stool on the glove. In terms of his central nervous system, he was awake, alert, oriented ×3, with no focal deficits. So he was assessed as having severe leptospirosis, Weil's disease, and they were querying dengue fever. So the plan for him, he was given an IV access and blood investigations were taken off. An ABG was done on room air. He had a blood culture, chest x-ray, and abdominal ultrasound done. He was administered Rocephin 2 grams IV, morphine 5 milligrams IM, and Gravol 50 milligrams IM. He was given oxygen therapy, IV fluid hydration, and he was referred to internal medicine. Now for his initial investigations, it showed a leukocytosis, anemia with severe thrombocytopenia, hyponatremia, and acute kidney injury. The liver function test showed a direct hyperbilirubinemia with mixed transaminitis. The coagulation studies were normal, and an ABG was done, which showed a metabolic alkalosis with a respiratory alkalosis. So in terms of the imaging, he had an abdominal ultrasound done, which showed no evidence of biliary obstruction, hepatomegaly, a bilateral renal cyst, and prostatomegaly. The chest X-ray was significant for moderate right pleural effusion and patchy perihilar infiltrates. For his further investigations, there was a positive IgM for leptospirosis. His dengue titers were negative. His blood culture showed 2 of 2 bottles, which grew gram-negative bacilli, and it was sensitive to augmentin and gentamicin. And the urinalysis showed blood 2+, protein 1+, and bilirubin 3+. He was assessed as having icteric leptospirosis, Weil's disease, moderate leukocytosis with thrombocytopenia, septic acute tubular necrosis, hepatic impairment, and pulmonary dysfunction with alveolar hemorrhage. Also, gram-negative bacilli bacteremia. So patient was referred to the intensive care unit, commenced on rocaffin 2 grams intravenous once daily, Nexium 40 milligrams IV, and Baralgin 1 gram IV once daily, continued on IV fluid hydration and strict input-output charting. At this time, the blood investigations were repeated. He had worsening of his anemia, worsening leukocytosis. The platelets had, however, improved, but there was worsening kidney injury and worsening of his liver injury. For the outcome, despite aggressive medical management, the patient deteriorated. He developed refractory hypoxia and hypotension. Cardiorespiratory arrest occurred approximately 48 hours after ICU admission. Resuscitative efforts were unsuccessful. The presumed cause of death was multi-organ failure due to severe leptospirosis, complicated by septicemia and pulmonary hemorrhage. And now we move on to case 3. So the presenting complaint, a premature neonate at 29 weeks, presented as a direct transfer from Savannah Lamar Hospital for NICU admission. Volunteers from UWI were stationed at the Savannah Lamar Public General Hospital when a 25-year-old female at 29 weeks of gestation was rushed into A&E with an active seizure. The patient was immediately resuscitated and given magnesium sulfate. An emergency lower segment C-section was done as definitive management of eclampsia. In terms of the maternal history, the mother had a history of pregnancy-induced hypertension and was compliant with Aldamate 1 gram twice daily. She was recently hospitalized for 4 days for elevated blood pressures, and she had complaints of headache and was disoriented to time and place. At delivery, delayed cord clamping was done. Patient was taken to the resuscitator, stimulated, and given positive pressure ventilation. He was noted to be cyanotic with a weak cry, a heart rate of greater than 100 beats per minute. He was intubated with a size 2.5 endotracheal tube secured at 8 centimeters at 20 minutes of life. Surfactant was administered in 2 aliquots, and blood investigations were taken off, a sepsis screen was done, and antibiotics were commenced. Plans were undertaken for the neonate to be transferred to the UWI hospital. Now, during transfer, the neonate was noted to have drifting saturations just before transfer. The decision to administer the second dose of surfactant was done with good effect. Soon after transfer into the helicopter, the neonate was noted to have a saturation of 71%, was cyanosed, apneic, and limp. There was no improvement or rise in the chest with intermittent positive pressure ventilation. The neonate was extubated and intermittent positive pressure ventilation administered using the NEO-T. The oxygen saturations improved to the mid-90s and the color improved. On arrival to UWI, NICU residents met the helicopter receiving a neonate being bagged with saturations of 90 to 94%. He was transported to the NICU and placed into a resuscitator, was pre-medicated with morphine, atropine, and cis-atracurium. The neonate was intubated and had saturations of 92 to 94% at that time. Now the APGARs was 7 at 1 minute and 9 at 5 minutes. The temperature of the neonate was 35.1 degrees Celsius with a pulse of 121 beats per minute and the GMR of 3.6 millimoles per liter. On examination, A male infant was seen lying in a resuscitator, anictoric, acyanotic, had adequate hydration status, and the mucous membranes were pink and moist. In terms of the head, there was no caput and no cephalohematoma. The anterior fontanelle, admitted 2 fingers, was flat and normotensive, and there was no posterior fontanelle appreciated. For the respiratory system, the respiratory rate was 60 breaths per minute. There was no nasal flaring, tracheal tugging, or intercostal recessions, but there was mild, intermittent subcostal recessions. No chest wall deformities were noticed. The chest expansion was equal bilaterally. Breath sounds were bronchovesicular with an equal throat. There were no crepitations, wheeze, or transmitted sounds. And the oxygen saturation was 93% on FiO2 of 100%. In terms of the cardiovascular system, the heart rate was 142 beats per minute. Pulses were regular, normal volume, was radial-radial synchrony, no radiofemoral delay. S1 and S2 heart sounds were heard, and there was no S3 or S4, no murmurs, and no edema. For the abdominal exam, it was soft, flat, non-distended, and non-tender. No masses and no organomegaly. The umbilicus was seen with 2 arteries and 1 vein. There was a normal male genitalia, and the anus was patent. For the CNS system, the neonate was asleep, comatose. There was decreased movements. The eyes were fixed and dilated, and there were no focal deficits. For the musculoskeletal exam, the spine was straight and continuous. The Ortolani and Barlow were negative. For the investigations, the initial ABG on ventilator support showed a metabolic acidosis. For the initial labs done at Savannah Lamar Hospital, the CBC, the white blood cell was 3.46 with an HB of 19.2. The packed cell volume was 61.2 and platelets of 175. The blood group was O positive with a direct Coombs test that was negative. Now, on arrival to UWI, a repeat ABG was done, and the assessment was severe respiratory acidosis, severe hypercarbia, and hypoventilation. So on assessment, it was a premature at 29 weeks neonate, moderate to severe respiratory distress with hypoxia, maternal eclampsia, to rule out sepsis, UTI, and meningitis, and a decreased GCS score, which was possibly due to sedatives that were administered. So the plan was to hyperventilate with the amber bag, give an LR bolus of 10 cc's over 1 hour, adjust the ventilator settings, and do a chest X-ray. Also, a urine culture was done, augmenting 30 milligrams IV was administered, ceftazidime 50 milligrams IV twice daily as well, aminophylline 2 milligrams QID. The neonate was kept NPO, an orogastric tube was placed on free drainage. IV fluids at 100 cc's per kilogram per day was administered, and there was strict input-output charting. For the clinical course, there was neonatal jaundice, acute kidney injury, transaminitis secondary to hepatic immaturity versus hypoxic injury, edema on day 3 of life, query secondary to prematurity versus hypoalbuminemia, GI bleed, and anemia and thrombocytopenia. The neonate required transfusions, which were initially delayed due to lack of consent. So for the clinical course, due to persistent abdominal distension, an X-ray was done and it confirmed necrotizing enterocolitis on day 3 of life. It showed markedly dilated loops of bowel with significant bowel wall edema, nil pneumatosis intestinalis, no portal venous gas, no pneumoperitoneum, and no air was seen in the rectum. Zosine, gentamicin, and flagyl were commenced. And here we have the X-ray that was done, as discussed earlier. Mother received updates via telephone, but the connection was unstable and the calls kept dropping. Mother was also unable to visit due to financial burden. Due to persistent abdominal distension, we ruled out Hirschsprung's disease. The neonate responded to rectal washouts of 20 milliliters per kilogram twice daily. The parents required 3 days of being taught how to do same, but had no resources to stay in Kingston. The neonate was assessed as having stage 2 necrotizing enterocolitis and to rule out upper GI bleed due to the history of melena. Continuing on the clinical course, there was possible Hirschsprung's associated enterocolitis, and the plan was to do over the sepsis screen, to continue the broad spectrum antibiotics, keep NPO, continue to administer IV fluids at 110% maintenance, give an orogastric tube on free drainage, aspirate to completion of Q4 hourly, and replace losses 1-to-1 with normal saline. Also, for twice daily rectal washouts. So there are quite a bit of social concerns. There was no roofing at their home in Savannah Lamar. Financial limitations prevented the mother from frequently visiting and dropping off supplies for the baby. Difficulty in receiving daily updates via phone call due to damaged power lines. Also, the cost for each visit to Kingston was $50,000 per trip, even with public transportation. There were no family members in Kingston or surrounding parishes. The parents considered relocating and changing jobs to facilitate being closer to the baby, but that was unsuccessful. Also, the nurses became concerned due to the inability of the parents to visit the infant. There was no supply of care products for the infant, including diapers, baby wipes, and barrier creams, and the avoidance of phone calls made to the parents. In terms of the social worker, there was a meeting in person, and meeting in person had proven to be difficult due to distance, and they were unable to do any home checks. The parents were directed to apply for the various social programs as applicable. So the PATH program, Lactating Women's Fund, grants from the Member of Parliament, and also Sandals Foundation, as the dad is an employee of the Sandals Group. To date, the child remains admitted on the pediatric surgical ward at UWI due to social concerns and is awaiting adequate weight gain to undergo rectal suction biopsy to confirm Hirschsprung's disease. And now we're on to the final case. So case 4 is of a 49-year-old male, and the presenting complaint was that he was talkative and agitated for 4 days. He has a history of bipolar 1 disorder for 21 years, compliant with quetiapine, 200 milligrams in the morning and 400 milligrams in the evening. His last relapse was noted to be 4 years ago. However, he has been progressively more expansive, talkative, and agitated for 4 days. And this was following a recent visit to St. Elizabeth after Hurricane Melissa. The stressor, the property his family owned, was destroyed by Hurricane Melissa. And it was expressed by the family that this is the worst he has ever been. For his mental status exam, he was appropriately dressed, had 4-point restraints. He was irritable, combative, and uncooperative. Speech was loud with increased rate. For the mood, he said, "I am God." Affect was expansive and he laughed inappropriately. The thought form, he had loosening of association and flight of ideas. His thought content, there was persecutory and grandiose delusions. For the perception, he denied hallucinations, but he was seen having conversations with himself. And he had poor insight and judgment. He was assessed as having a manic episode, with the trigger being Hurricane Melissa. The plan, he was administered Haldol 10 milligrams IM, DPH 50 milligrams IM, diazepam 10 milligrams IM as well. And for Haldol 10 milligrams IM and DPH 50 PRN thereafter. For his outcome, patient was admitted to the psychiatric ward. He was maintained on quetiapine 400 milligrams twice daily and Depakote 500 milligrams at night. There was no significant improvement, however. He was unwilling to engage in interviews. His persecutory delusions persisted. He was dismissive, and he had thoughts of self-harm and staff harm were expressed. Patient gradually improved, but with a new baseline, and was later discharged on day 24 of admission with close follow-up. Thank you.
Thank you, Dr. Williams, for such thought-provoking and very interesting cases. To the audience, if it is you have any comments you want to share or any questions that you would love to ask, please post them in the chat and they will be answered accordingly when acknowledged. I invite Dr. Barrett once more to introduce our next presenter, who will be delving into our discussion segment.
It is once again my honor to introduce our second presenter, a colleague whose dedication to medicine is as inspiring as her approach to life beyond the hospital walls. Dr. Jessica Roy is currently a third-year emergency medicine resident, deeply immersed in a specialty that demands sharp clinical judgment, adaptability, and composure under pressure. For over half a decade, she has committed herself to the practice of medicine, building a strong foundation that began in Hanover and was shaped through her education at Mount Alvernia High School for Girls, Montego Bay Community College, and later at the University of the West Indies, Mona. Her decision to pursue emergency medicine was driven by her love both for clinical problem solving and hands-on procedures, as well as the dynamic variety that the field offers. No 2 days are ever the same, and she thrives in that unpredictability. Beyond the fast-paced environment of the emergency department, Dr. Roy values living life fully. When she's not working, she's most likely traveling, embracing new experiences, cultures, and well-deserved moments of adventure. Today, we have the privilege of learning from her expertise, her experiences, and her perspective. Please join me in warmly welcoming our colleague, Dr. Jessica Roy.
Good afternoon, everyone. Just allow me a moment to set up my presentation. Okay. So it is indeed my pleasure to lead this discussion about the second wave after Hurricane Melissa, looking at post-hurricane burden of medical, traumatic, as well as psychological diseases. So before we get into Hurricane Melissa, we know that natural disasters are not a new phenomenon to Jamaica and the wider Caribbean. We have experienced disasters before. However, Hurricane Melissa was unprecedented. Depicted here on your left is an illustration of the 1692 earthquake that took most of Port Royal from Jamaica. At your top right, we're looking at a schematic diagram showing Hurricane Gilbert headed towards Jamaica in 1989. And at the right inferior aspect is a picture showing loss of property as well as fishing boats onshore following Hurricane Beryl in 2024. Therefore, we're not new to disasters. However, how we move forward from disasters is what we need to focus on, as well as looking at what has happened. Now that the disaster has passed, where are we now? On October 28th, 2025, at about 5:25 p.m., Hurricane Melissa made landfall near New Hope in Westmoreland. At that time, the system had sustained winds at 185 miles per hour and was categorized as a Category 5 hurricane at that time. It was the strongest hurricane to hit Jamaica in its history, and at present, we're still recovering as a country. Hurricane Melissa was the 13th and final named storm in the 2025 hurricane season. Up to 1 month post-Hurricane Melissa, 9,000 people were still displaced and living in shelters among rubbles in the affected parishes. The hurricane not only impacted physical lives, but also included a great loss of property and fiscal structure. Many people lost their jobs, their homes, and their family members, and so priority became surviving despite the odds. When looking at the fiscal impact of Hurricane Melissa on Jamaica, as per the Planning Institute in March of 2026, they noted that the estimated loss was all up to 1.9 trillion Jamaican dollars, which is a very large figure. Jamaica was affected by Hurricane Melissa, but so were other countries. Our neighboring Caribbean islands, such as Cuba, the Dominican Republic, as well as Haiti, were also affected, and the hurricane caused significant instability in these countries. Okay. Haiti noted a surge in its waterborne diseases, and Cuba noted an increase in vector-borne diseases as well as infrastructural damage to their healthcare facilities. Depicted here are images from our local newspaper, The Gleaner, that showed destruction of houses as well as flooding just in front of the Mandeville Regional Hospital in Manchester. Here are some further images from The Gleaner, and as we can see, there was significant flooding, loss of homes and structures, as well as damage to property, as we can see a car under a light pole. Hurricane Melissa damaged up to 156,000 dwellings across the parishes of St. Elizabeth, Westmoreland, Manchester, St. James, Trelawney, and Hanover, with 24,000 of these properties completely lost. As such, even though we consider the fiscal damage and burden that the hurricane brought to the island, as healthcare providers, it is our duty to look at how our healthcare system was affected by the passage of this hurricane, keeping in mind that a hurricane season occurs every year, and with all the environmental changes that are occurring, this is something that we must plan for, must put things in place for. And so we look at the second wave. Now, for the second wave, as healthcare providers, we are very much concerned about the disease burden associated with Hurricane Melissa. From flooding events and infectious diseases to physical health and trauma, as well as mental instability due to post-traumatic stress disorder. The loss of access to care and deterioration of patients due to inadequate resources to manage their chronic illnesses are also major concerns after a disaster. Jamaica has 4 regional health authorities, and these comprise of over 300 health centers and 24 major hospitals. All facilities prior to Hurricane Melissa making landfall were put on high alert in recognition of a Category 5 hurricane. However, after the passage of Hurricane Melissa, 5 hospitals were severely damaged, as well as 134 health centers, as per the Pan American Health Organization news bulletin from October 2025. So the hospitals that were affected mostly included the Black River Hospital, the Corner Regional Hospital, Noel Holmes Hospital, the Savannah Lamar Public General Hospital, as well as Falmouth Public General Hospital. Losses include infrastructure, electricity, water, connectivity, as well as waste disposal facilities. Other hospitals suffered minor damages here and there, but they were able to go back to normal operation within a short time period. The University Hospital, for example. Depicted here are images from the Corner Regional Hospital, whether sent through group chats or posted online. This image in particular is of the obstetric ward on the nurses' quarters at Corner Regional Hospital, which was completely destroyed following the passage of Hurricane Melissa. These are images of the Black River Hospital that was rendered inoperable after full analysis post the passage of Hurricane Melissa. As we know, most of the buildings, they have no roofs, the roads are flooded, and some buildings are completely flat. With 5 major hospitals and over 130 health centers affected, there was a complete disruption of our healthcare system, particularly in Western Jamaica. As such, charity groups, aid groups came to our assistance as soon as possible. And as early as October 31st, there were field hospitals that were being established. One of the first being the Samaritan's Purse Field Hospital in Black River, St. Elizabeth. The disruption not only affected direct patient care, meaning there's no hospital to actually serve a patient and take care of a patient, but staff were absent or injured, whether through blocked roads or they were injured throughout the storm. There was destruction of the physical structure, disruption of waste disposal, loss of medical records, loss of medications, as well as loss of medical equipment. With that came the surge of patients who presented to other hospitals and other health centers that were left standing. And so our colleagues in other unaffected parishes had to manage that burden that came. Patient numbers increased at University Hospital, in particular, with an associated increase in wait time. This was coupled with disruption of elective cases, an increase in emergency cases, and the acceptance of all transfers from the affected institutions. Certainly, myself and my colleagues who were in the department following the passage of Hurricane Melissa, we were very aware that at any point in time, 2-3 ambulances would be coming in. The air ambulance would also be coming in with transfers from Western Jamaica. There's also the abrupt disruption in access to healthcare. So this is a news excerpt from The Star, which is one of our local newspapers here in Jamaica, that speaks of a story of a patient, Joel Winter, who is known to have sickle cell anemia, and because of being marooned in his community, had difficulty acquiring analgesia after suffering from a vaso-occlusive crisis. And so the patient reported being in significant pain over a prolonged period of time, being unable to seek medical care due to being marooned in his community. He was not unique in his experience. Several persons in parishes such as St. Elizabeth, Westmoreland, and St. James were marooned for days in their communities without access to their families, roads, health centers, hospitals, and food in some cases. This is a table that looked at the preliminary health and facility impact from Hurricane Melissa, dated November 2nd, 2025. It looked at the major hospitals that were affected by the passage of the hurricane and what their status was post Hurricane Melissa. We note that the Black River Hospital was inoperable when this assessment was done. The roof collapsed, there was wall destruction, extensive flooding, the operating theater was rendered unusable, and the laboratory system was completely destroyed. Other hospitals were severely damaged, such as the Falmouth Hospital and Corner Regional Hospital, with flooding or specific aspects of the hospitals being completely destroyed or severely damaged. Noel Holmes Hospital as well as Savannah Lamar Hospital were both categorized as damaged, and they were noted to have flooding in some areas and leaking roofs in other areas. Some services continued, whereas others had to be paused. So, according to the Pan American Health Organization, as of January 2027, the national hospital bed capacity was at 90%, with several major hospitals under strain. The strain came from the surge of different disease pathologies occurring now post Hurricane Melissa, the surge of infectious diseases, the surge of trauma just after the passage of the hurricane, as well as the surge in mental health illnesses. Corner Regional Hospital was noted to be at 149% capacity. Maypen Hospital 145, Mandover Regional at 143, and Linstead Hospital at 112% capacity. And as we know, 100% tends to mean full capacity. So these hospitals were way past what they would normally be able to handle and manage on a regular day. We will look specifically at the different aspects of surging, so the different disease processes that really contributed to the patient overload, that contributed to the strain on the different hospitals, and we'll go further into that now. As it relates to infectious disease surge, it really came about because of extensive flooding. So there was flooding due to heavy rains, the overriding banks, the sea, and this not only caused water to settle around dwelling areas, but contaminated water supplies for patients. It also led to patients being marooned and with limited access to emergency supplies during and immediately after the hurricane. Animals were also killed and persons also lost their lives through drowning. So contamination of water supplies leads to several issues: acute gastrointestinal diseases, vector-borne diseases, skin and soft tissue diseases, as well as sanitation breakdown. And just so that we understand the level of flooding that I'm speaking about, these are images that were taken from the Gleaner that showed extensive flooding in southern Jamaica post Hurricane Melissa. It is well known that hurricanes affect pathogenic diseases. It is well known, well documented, that the frequency and passage of hurricanes generally leads to an increase in vector-borne diseases, respiratory diseases, as well as acute gastrointestinal diseases. This is a report by Dr. Lisa Manez, who looked at the effects of hurricanes on pathogenic diseases. And as we can see, it's confirmed. Evidence shows that there's increase in airborne and waterborne diseases from the environment. In addition, infections that result from overcrowding due to increased number of patients in shelter areas due to loss of their homes and other dwelling areas. This is another excerpt from the Jamaica Gleaner, and this is our CMO, Dr. Besesa McKenzie, reporting on new 11 cases of leptospirosis and 2 cases of tetanus. And this is dated November 17, 2025. In this posting, they had put out signs and symptoms to look out for in the event that you are ill and you think you may be having leptospirosis, such as fever, headache, chills, body ache, vomiting. This was posted on Facebook, on Instagram, so that patients who still had connectivity, who could still access these social media platforms, would be able to see what is going on in terms of a rise in diseases following the hurricane. This, however, may not have reached some of these patients who were still marooned, some of these patients who did not have access to the Gleaner that physically publishes newspapers, or connectivity to look on social media platforms to learn about these signs and symptoms that they need to look out for. And this was a press release from the Ministry of Health and Wellness dated November 24th, 2025, that declared a leptospirosis outbreak in Jamaica following the passage, almost 1 month after the passage of Hurricane Melissa. As of November 21st, 2025, there were 9 cases confirmed at that time, 28 suspected or probable cases, and 6 deaths among the suspected cases, all being male. So for us to simply look at leptospirosis for a moment. Why is it of concern? Why are we so worried about it? Why, with just 28 suspected cases, we are on high alert and we're declaring an outbreak of this disease? Leptospirosis is a zoonotic infection. It's caused by spirochetes, and they're typically transmitted when contaminated fluid enters the body through the skin, mucous membranes, and conjunctiva. After entry, the organism disseminates hematogenously during the leptospirotic phase, spreading to multiple organs, particularly the liver, kidneys, lungs, as well as the CNS, central nervous system. The bacteria adheres to endothelial cells and disrupt intercellular junctions, causing leaky capillaries and a vasculitis, and which underlies many of the clinical manifestations of leptospirosis. In the immune phase, host immune response contributes to tissue injury. Renal involvement takes the form of tubular interstitial nephritis and tubular dysfunction. This leads to acute kidney injury and electrolyte disturbances. The hepatic dysfunction that comes with leptospirosis is from hepatocellular injury and cholestasis, producing jaundice without massive necrosis. Severe disease, or Weil's disease as we know it, reflects a combination of direct endothelial damage and immune-mediated injury. This leads to multi-organ failure, pulmonary hemorrhage, and shock. As of January 27, 2026, the Pan American Health Organization reported 124 suspected cases and 40 confirmed cases of leptospirosis, with 14 related deaths. All deaths were in men. They also reported increases in dengue, diarrheal diseases, and tetanus. Dengue in particular, we noted a number of 544 suspected cases of dengue post the passage of Hurricane Melissa. However, we had 0 confirmed cases as of January 27, 2026. How can we protect ourselves from leptospirosis? We can start with education. Educating the public. As physicians, we learn a lot in medical school. As other healthcare practitioners, we've learned these things already. It is our duty to disseminate this information to persons who just do not know the risks that are involved post the passage of a hurricane, post flooding from heavy rains, etc. So it's to inform them. Rodents can carry these spirochetes. You can get infected from interacting with contaminated food, water, etc. You need to protect yourself. Don't swim in dirty water. Wear protective shoes when you're going out. Always boil your drinking water or use chlorine bleach. And look out for signs and symptoms so that if you're having early signs and symptoms, then you can get health assistance at nearby hospitals and health centers as soon as is possible. And it is important that we disseminate this information prior to a natural disaster. At the beginning of every season, in the middle of the season, and at the end of the season. We never know when a natural disaster can come. Yes, we get 2, 3, 4 days warning that it's coming. However, trajectory changes all the time. And so it's important that we keep these things present. We keep the information going and circulating so that persons are aware of the risks involved and when to seek medical attention. I know I mentioned tetanus earlier in passing, but it made it was a big deal following Hurricane Melissa. Because for one, we had a patient who died from tetanus in Jamaica following Hurricane Melissa. We had a total of 2 cases, one in Westmoreland and one in St. Elizabeth. Now, this is an excerpt from the Gleaner, our local newspaper, as I mentioned, that detailed on the 27th of November 2025 that we had confirmed cases of tetanus in Jamaica. And it noted that tetanus is a serious disease of the central nervous system by a toxin-producing bacterium. And it made sure to mention that tetanus is commonly known as lockjaw. As we're disseminating this information to patients and the general population, we need to keep in mind that they may not be familiar with the jargon that we use in the medical field. So speak to the patients in ways that they can understand. Disseminate information in the common tongue. Lockjaw. We know lockjaw. Everybody knows lockjaw, but some people may not know tetanus. So I'm happy that in publishing this, the Gleaner included the term lockjaw. So tetanus results from infections with spore-forming Clostridium tetani bacteria, usually acquired via contaminated wounds and burns. C. tetani releases a potent neurotoxin causing muscle spasms, rigidity, as well as dysautonomia. Important complications include laryngeal spasm and resultant airway obstruction and respiratory arrest, nosocomial infections, and sequelae of prolonged immobility. The treatment of tetanus is multifaceted, requiring source control, antibiotic therapy, and antitoxin administration. With prolonged quality intensive care, many patients survive with good functional outcome. Tetanus is usually diagnosed based on clinical signs and symptoms, but microbiological tests can serve as useful adjuncts. From the epidemiology of tetanus in Jamaica, which was a study done covering 1993 to 2010, it noted that there was about a 15% mortality associated with tetanus, specifically among severe cases where patients were hospitalized. Depicted here to your right is an image that shows some of the core features of having tetanus, additional features that we can look out for, complications related to the disease, and complications related to admission. So trismus, rigidity are some of the signs and symptoms, as well as fever and dysphagia that we can look out for when managing these patients or when patients are presenting and we're not sure what's going on. We need to keep these things in mind. Some of the complications, aspiration pneumonia, rhabdomyolysis, laryngospasm, as I had mentioned before, as well as hyperpyrexia. And even with admission, there are several poor outcomes due to admission themselves, such as upper gastrointestinal hemorrhage, deep venous thrombosis, ventilator-associated pneumonia. So even though patients may be admitted, they may have further complications from this admission. As I mentioned, the burden of infectious disease is evident in the fact that we have hospitals who are almost at 150% operating capacity based from their baseline. And so we need to inform the public of these diseases that we are to look out for post a hurricane, post a natural disaster, post flooding and heavy rains, so that we can see patients earlier, manage patients earlier, keep admissions low, and certainly keep death tolls low. I'll be moving on now to trauma surge following the passage of Hurricane Melissa. Depicted here is a picture of some volunteers from the Jaja Foundation, which is Jamaicans Abroad Assisting Jamaicans at Home, which is a lovely foundation that is very, very familiar to us here at University Hospital. They lead a lot of training sessions in terms of ultrasound and POCUS use, and as well as aiding to develop Jamaica further, assisting in building health centers and other volunteer services. So I thought it important to include them. So trauma surge speaks to a sudden and unexpected increase in the volume and/or severity of trauma patients that overwhelms the hospital's emergency medical services. This can happen in cases of mass casualties such as shootings, traffic accidents, natural disasters, or violent attacks. Trauma surges in relation to natural disasters such as hurricanes tend to occur in two phases. The first occurs 24 to 72 hours immediately post the hurricane, and the second aspect occurs during the recovery phase, days to weeks. Some of the mechanisms of injury that occur during a trauma surge include blunt trauma and crush injuries, lacerations and falls, landslides, related trauma, and injuries during cleanup. This is a study, a descriptive study that was done that looked at injuries and fatalities in the United States and their impacts on emergency preparedness and operations. It examined trauma and fatalities from these natural disasters, and they note that rising disaster frequency increased the trauma associated with them, up to 17% from 2015 to 2019. They noted that trauma was the major cause of morbidity and mortality in the acute phase, and injuries include blunt trauma, crush injuries, lacerations, and falls, as well as some other common ways of death through trauma included structural collapse and vehicle-related injuries. Some of the high-risk groups who are at risk in trauma surges include young males, who are generally very helpful. They're assisting with repairs and cleanup events, as well as the elderly who are at risk due to their several comorbidities and simply being elderly. Trauma surges in this case are driven not only by human activities, but also by environmental hazards. As of today, so following passage of Hurricane Melissa, this was reported today that there were 350 reported cases of injury during and after Hurricane Melissa, with at least 45 deaths directly linked to the injuries sustained, as well as 11 missing persons who are still unaccounted for. Injuries occurred through a variety of mechanisms, and with limited availability to emergency medical services, some patients succumb to their injuries, unfortunately. The sudden increase in trauma patients can put a strain on emergency departments and its limited resources. These include ED overcrowding, which we already struggle with on a regular day, a decrease in blood and other blood products from the blood bank, strain of imaging modalities, as well as ED staff actually being victims in some trauma surge scenarios. So the emergency priorities for trauma surge patients include: 1, rapid triage and early identification of high-risk patients. It includes looking at patients with airway compromise as well as hemorrhagic shock. 2, prioritize life-threatening injuries. So for patients with airway compromise, early intubation, the treatment of pneumothorax, and oxygenation for patients who are hypoxic. Looking at the third aspect, early wound care plus tetanus prophylaxis. So early irrigation and debridement of wounds, administering the tetanus prophylaxis, as well as giving antibiotics as needed for these patients. We also look at patient flow and surge control, as well as public health integration into the management in this period when we're having trauma surges. And this becomes increasingly important because a patient who is triaged to a level 4, who is sitting and waiting in the casualty area, may not understand that in the main emergency area, there is a whole trauma surge going on. There are 30, 40, 20, 15 patients who are there, who are critically ill, who are being attended to by emergency physicians. And so the wait time for a ESI 4 patient may be a little longer because of redistribution of staff. Therefore, it's very important that we integrate public health into these periods when we have surges of infectious disease and trauma, so that patients can be aware of what exactly is happening. Now, one thing that we can use to guide us, and this is us looking back and then paving a way forward. So a trauma surge index is a validated metric developed to measure hospital capacity strain by identifying periods of high volume and high acuity admissions that lead to increased patient mortality. It allows hospitals to analyze their surge capacity retrospectively, identify bottlenecks, and inform staffing and resource investments. What this essentially means is that it gives you a chance to look back at what has happened. How did we manage post-Hurricane Melissa? What could we have done better? And what areas do we need to invest in more in the event that we have another trauma surge? For example, if you consider a type C hospital, perhaps, that generally has 1 to 3 chest tube sets available on a regular day. In an event that that area has a trauma surge and you're bombarded by trauma patients now, you're going to need way more than 3 chest tube sets. And so getting a trauma surge index, identifying these periods of trauma surge will help you to allocate your resources better to manage these patients better. Because it's known, it's published that patients who are admitted or seen during these high surge periods tend to have a higher mortality, 9.9% compared to 6.3% during low surge periods. And for healthcare facilities who do not know when these periods are there, meaning you go on the floor and you see, whoa, we have a lot of patients today. But to be objective in how you assess the patient load during periods of surge or high surge or low surge, utilizing a trauma surge index would be a good option. And we know that a trauma surge index of greater than 3 indicates a high surge period. Now, this is a study. This study established the trauma surge index. This was a 2015 study, and it was a retrospective observational study from hospitals in the United States and Canada, looking at 250,000 trauma patients from 2010 to 2011. There's a large multi-center trauma registry cohort. And the objective was to develop the trauma surge index and assess relationship between hospital capacity strain and patient mortality. They looked at things such as admission volume, patient acuity, hospital baseline capacity, and tried to identify high surge versus low surge periods. And the findings were, as I mentioned before, significantly increased mortality compared to low surge periods, looking at the high surge periods, with an up to 5-fold increase in mortality during these extreme capacity strain periods. So it is important that we identify these periods. We know that the hurricane season is coming up. We know that we have flooding seasons in certain other countries, and then we need to assess retrospectively, when we've had these periods pass before, what was our trauma load like at that time? Were we able to manage? Did we have enough resources? Were we short on staff? Were we short on actual disposables? Were we short on the physical machinery to use in emergency departments and to use in a hospital as a whole? Were any of these things compromised, and did this affect patient outcomes? If the answer is yes, now we know, and we can address these different areas accordingly moving forward, because as healthcare providers, patient outcome is our priority, and whatever we can do, we should do to ensure that patients have the best outcome. This study I included because this is a local descriptive study by our neurosurgery colleagues that looked at the health system and a neurosurgical response to Hurricane Melissa. I included specifically because it spoke to trauma, not necessarily in the emergency department, but certainly we utilize our neurosurgery colleagues often. We make several referrals to them. And so if they are noticing something, it's in our best interest that we keep abreast of what is also going on. Now, some of the key findings that they noted in this descriptive study was that trauma dominated the early phase. And we understood that. This just reinforced it, that in the acute phase, the first 1 to 3 days, many of the patients who present will be trauma patients and not necessarily infectious disease patients. It noted that the healthcare system was strained, particularly in Jamaica, due to overcrowding, limited ICU or operating theater capacity, as well as workforce shortages. As it related to neurosurgical challenges specifically, they noted a high demand with limited specialists and resources, and a need for prioritization and rapid decision making. It also spoke about effective response strategies such as surge capacity planning, reverse triaging, as well as task shifting and a team-based approach to care of patients. So definitely a well-written descriptive paper from our neurosurgical counterparts that underscores some of the things that we have kept in mind, that trauma is one of the first things that we're going to see following a natural disaster, that the surge is likely to come depending on the extent of the disaster that we face, and particularly in hospitals and health centers that are close to ground zero ground zero, then they will, once they're able to see these patients and facilitate these patients, then they will get the surge first. However, if you're rendered inoperable, such as how Black River was rendered inoperable, then the surrounding and supporting hospitals will certainly get the surge and will need to be able to manage this increased number of patients. Finally, we'll take a look at the mental health surge. And mental health is just as important as physical health. I just need to ensure that we are all on the same page about that. A mental health surge post-Hurricane Melissa describes a rapid increase in acute psychological distress, trauma-related disorders, as well as emotional strain among the population. The surge captures the spectrum of immediate psychological issues, as well as delayed response and long-term reaction to loss of lives, communities, and livelihoods. There are different phases, similarly to how we have in the acute phase. There are trauma patients versus in the recovery phase are more infectious disease cases. In the different phases for a mental health surge, in the immediate phase, which are always the days we think about things such as acute stress disorder, fear, insomnia, as well as anxiety disorder. In the short term, which is about weeks to months, we're seeing more other things such as post-traumatic stress disorder, generalized anxiety disorder, a relapse of major depressive disorder, as well as schizophrenia and schizoaffective disorder relapses. In the long term, there can be development of chronic mental disorders in patients who were never previously diagnosed, as well as substance use disorders. Some of the drivers of mental health crisis during a mental health surge include direct trauma. For example, if you're in Black River and you were there looking through your window, you saw when your neighbor's house collapsed on them. You saw that. Or you were in your house when your roof collapsed on you or it was blown off and your family member was injured and you were injured. These are direct trauma that have affected other people, that have affected patients. So witnesses, injury, loss of life, as well as threatening situations. There's loss and displacement. So following from that example, you were there, the roof blew off, you had to run out, you sheltered with your neighbor also lost their roof, you ran down to the church roof was also gone. And so everybody was running towards the one standing building that was left in that area. Thinking about these things can be quite detrimental. Just the concept of losing your home, your dwelling place, as well as all your belongings, your businesses, the church where you worship, and the school that you went to. Thinking about all of these things being completely destroyed can be quite a burden for patients to bear. Food insecurity as well as healthcare disruption also plays an integral role in mental health surge. Being unable to find breakfast, lunch, or dinner is certainly a concern for me on a regular day during a busy shift, much as for persons who have gone through a very traumatic event, a hurricane that took the lives of their neighbors and their friends and their family members. And now all the food that they had bought for the hurricane is completely destroyed. The shops and the wholesales that are in their communities are completely destroyed, and they are marooned in their communities. How will they eat? These things can be quite detrimental. Just thinking about the fact that you went through something like this can be quite detrimental to some patients' mental health. And continued exposure. Some people, as of today, April 23, 2027, have not, 2026, I'm sorry, they have not gone back to a normal living condition. They haven't gone back to what they consider their normal life. And so patients are still going through it up to today. Some of the patients were at a higher risk of developing mental health disorders following the passage of Hurricane Melissa include children and adolescents, elderly patients, women, patients of low socioeconomic backgrounds, patients with pre-existing mental illnesses, whether it be from the disruption in the healthcare system affecting their access to medication, or from the acute stressor precipitating a relapse in these patients. And let us not forget ourselves. First responders and healthcare workers, we are at the front line. We see everything first. And so it can be difficult for us to process some of the things that we see on a daily basis, especially following natural disasters, and taking into consideration managing our mental health sometimes is placed on the back burner. And so we are certainly at risk of developing mental health illnesses following exposures to these natural disasters. Depicted here are excerpts from Gleaner. As you can tell, the Gleaner covered quite a lot of the Hurricane Melissa events or incidents over. There were certainly a lot of images from the affected parishes. And this one specifically in the center mentioned mental health advocates saying trauma from Melissa is only now surfacing. So what we have noticed is that in the acute phase, trauma search is what may pop up more commonly. In the early recovery phase, the infectious diseases, the waterborne diseases, the respiratory illnesses will become predominant during this time. However, right there, right in the middle there, the development of mental health conditions have begun. It may be that we're not monitoring for these illnesses, the development of these illnesses at that time, because the burden of infectious disease is very present and pressing. So screening for mental health disorders is not as frequent as it needs to be. So towards the end of the recovery phase, we're seeing a surge in mental health illnesses, mental health burden. When patients actually sit down, the hurricane has no pass. Red Cross came, they assisted you. The Jamaica Defense Force was there. You saw your member of parliament. You saw volunteer doctors come down. You went to the Samaritan's Purse. You got treated for your nails stick to your foot. Now you are sitting in where was once your home. There is no home there. There is no food. There's no clothing. There are no documents. There are no degrees to show. There is nothing that's left for you there. And so to sit with that and to be okay with that is very difficult. To sit with the idea that you will have to rebuild from scratch, from ground up, for patients who are 50, 60 years old with 2, 3, 4 children, with relatives who are dependent on them. It is quite difficult. And as I'm about to show you, this has happened before. Me mentioning that these patients are at an increased risk of developing mental health disorders that can become chronic has been demonstrated in research before. And so we need to take it seriously. We need to screen for these mental health disorders from early. We know that the elderly patients are at risk for it. We know that patients who have chronic mental health disorders are at risk of relapses. We know that patients who face direct trauma are at an increased risk of acute stress disorder, etc. So we need to screen for these disorders and as well as manage these patients appropriately. As I said, this has happened before. So this was a study that was done in September 2017 that looked at the association between adverse experiences during Hurricane Maria and mental and emotional distress among adults in Puerto Rico. It was a cross-sectional observational study and with a sample size of about 1,500 adults. What it showed was a strong association between disaster exposure and moderate to severe depression and anxiety. It also demonstrated that individuals with multiple adverse exposures had significantly increased odds of psychological distress. Now, you are here for Hurricane Melissa in October 2025. We are now in April 2026, and the National Hurricane Center has since put out the proposed names for hurricanes for this season. Simply thinking about the fact that another hurricane may come is anxiety provoking for some of these patients, for me in particular, because it is just a reminder that we've been through something so disastrous, and the possibility lies that we could be exposed to another disaster such as Hurricane Melissa. Knock on wood, God forbid. However, it has happened before, and we see that repeated exposures to these natural disasters predisposes patients to adverse mental health outcomes. So we need to be screening for these illnesses, and we need to be treating these illnesses appropriately as well. Again, this was another study that was done that looked at the impacts of hurricane and flooding on mental health outcomes. And this was done in the United States. This was a systematic review and a meta-analysis. And this covered 50,000 individuals. And it was a very similar outcome as was demonstrated with the study in Puerto Rico, that patients were at a higher risk of developing post-traumatic stress disorder, depression, and anxiety in exposed populations. Now, the International Federation of the Red Cross, they were on the grounds in Black River. I noted a post from them where they did preliminary training for some volunteers, how to do preliminary mental health assessments and how to advise patients preliminarily on mental health concerns, how to identify patients who were at risk. And so from their operations in Jamaica, following the passage of Hurricane Melissa, the head of operations, Dorothy Francis, noted that while physical wounds may heal and houses can be rebuilt with time, emotional wounds can linger long after the crisis is over. Mental health and psychosocial support programs are among the least expensive interventions in humanitarian response, yet their impact is priceless. And I certainly agree with that statement. This was, I included this particular article because this was something that was written before Hurricane Melissa hit Jamaica. Hurricane Melissa was October 28th, but certainly in October 22nd, 2025, it was a storm surge at that time. And I remember seeing the bulletin that it was a storm surge at that time. But this article looked at how physicians can play a key role in recovery and rebuilding in terms of mental health impact in after natural disasters. It noted that physicians could do early screening and identification, provide psychological first aid, as well as to refer to mental health services as appropriate. It mentioned preparedness implications. So taking into consideration the preparations for a trauma surge, you're ensuring that you have your equipment, you're ensuring that you have ultrasounds available, your bedside x-rays, you're ensuring that your staff is ATLS trained, you're ensuring that those things are in place for physical trauma. For infectious diseases, you have protocols. There are posters all over departments on signs and symptoms of leptospirosis, what samples to take off. The same amount of energy and effort needs to be put into preparedness for mental health disasters. So ensuring that there are established counseling services available, how to get through to these counseling services, who to reach out to, who is the main person on the ground, on the floor, where are the offices? All physicians, all nurses, all allied healthcare workers need to be able to identify these things so that patients can be directed as appropriate. And this needs to be included in the preparedness aspect in disaster management planning. Also, in the establishment of community support systems and a community-based approach to mental health. Certainly in Jamaica, we have our mental health team that is well established throughout the island. I've worked in several parishes, and in all of these parishes, I know that there's a community mental health team that patients' families can call and they can get assistance from. Effort, resources, and time need to be put into some of these systems that already exist so that in the event where we have a mental health surge, we have some of these resources already in place to combat this surge and so that we have better outcomes for our patients. Last but certainly not least, we cannot forget about ourselves. So this was from the PAHO representative in Jamaica. This was an excerpt taken from the PAHO website, and it noted that healthcare workers showed up even when they were victims themselves. They were providing care in tense and crowded rooms while worrying about their own families. And I will speak about a friend that I know who works at Black River Hospital, who, when I visited the institution in November 2025, and I saw her, I asked how she was doing, and she said not well. Ironically, she works in psychiatry, and she was there seeing patients in the emergency department. She was writing outpatient prescriptions for patients and in that area at that time. This is a physician who lived in St. Elizabeth, had established her life there. She lost the house and the car and the dog. They all went. She was at work during this time, and she relayed to me that it was a very traumatic experience for her, going through the hurricane, being at work, seeing the roofs being blown off the wards, and nurses trying to rush out with patients to come to another building. It was a very traumatic experience for her. And she said she needed to reach out to another colleague to get mental health support so that she'd be able to push forward. Because though you are a physician and you do have patients to serve, you do need to take accountability and take responsibility for maintaining good mental health in yourself, especially if you've been exposed to a disaster such as a Category 5 hurricane. So while she's there serving her patients, she made it a priority to reach out to another psychiatrist for assistance in managing her mental health, considering all that she went through. And for us as physicians, I know once we come to work, once we're on the floor, our patients are our priorities. We do need to take time out of our days and our weeks to consider and work on our mental health. We are at the forefront of everything. Everything comes at us very fast, very unexpectedly sometimes, and it can cause a mental strain and mental distress. So if you are suffering, then you need to be reaching out for help. Ask a colleague, ask a friend, go to a private psychiatrist. These are things that we need to do for ourselves so that we're better able to serve our patients. Okay. So as a department, as emergency physicians, as a hospital unit, what can we do? What can we do? Natural disasters will continue to happen, hopefully, not to the extent that Hurricane Melissa came and did, but due to environmental changes, we understand that we're at risk of further natural disasters. And so we can look at some things that we're able to implement in the emergency department and in a hospital unit at large to combat some of the effects of these natural disasters. Now, this is a diagram that looks at the disaster management cycle. As noted in the key, the after events is in yellow and the before events in green. So there are 4 areas that we look at in the disaster management cycle: mitigation, preparation, and then the disaster happens, then we look at response and recovery. So healthcare system readiness directly impacts outcomes, including mortality and morbidity during disasters. Preparedness requires multidisciplinary collaborations between government agencies, hospitals, public health bodies, private sector, as well as the communities. In looking at the mitigation aspect, so before the event, we can do something that's called a hazard vulnerability analysis. And what this is a tool that is used by organizations to identify, prioritize, as well as mitigate natural, technological, and human-caused hazards. Essentially, it estimates the probability of a hazard and its likely impact on emergency services to guide emergency preparedness and resource allocations. And just so that we get a better understanding of what this can look like, I've done a earthquake focus hazard vulnerability analysis versus a hurricane focus. So in the earthquake focus analysis, you focus on building code enforcement, retrofitting structures, ensuring elevators are safe, reinforcing medical facilities to continue operating post a major earthquake. Some of the focus in a hurricane focus vulnerability analysis looks at evacuation planning, protecting assets from water damage, securing facilities against high winds, and managing long-lasting emergency situations. Yes, there can be crossovers depending on the type of disaster that we're facing, but it does help an institution to realize where the weaknesses lie before something even happens. And so do your analysis based on the location of where you are, the patients that you see, the resources that you have. If this natural disaster were to strike, what would you be most at risk of losing? What would go down first? What would be your weakest point? What would render the operations in your department bring everything complete to a halt? Doing a hazard vulnerability analysis helps institutions to identify these things and mitigate them. So put things in place to prevent them from happening in the first place. So some core strategies in mitigation include things that can help with business continuity. So identify critical services and staff, plan for staff shortages and supply limitations, suspend non-essential services, and ensure supply chain alternatives. Some things that can strengthen infrastructure resilience include backup power, communication, and data systems, as well as isolation capacities, such as a negative pressure room. In looking at before the disaster, in preparedness, so preparedness is really planning for an effective response. So what have we done as a team, as a department, that can ensure that if we do need to respond, we are ready for that response? So disaster drills need to be done. These need to be formatted into every emergency department, stockpiling of supplies and keeping abreast of where the resources are. So daily checks on resources that you have, making sure that orders are coming in when you notice that something is running low, as well as ED surge protocols. So if you've done your trauma surge index, you know that you are greater than 3, you know that a surge period is coming up in the next 2 to 3 months, then having disaster drills for these particular disasters need to be a recurring thing. And also having protocols in place that each member of staff is abreast of needs to be done as well. I know at Corner Regional Hospital, they frequently do emergency response to a airline crash, for example, because a national airport is right in the vicinity of Corner Regional Hospital. They frequently do drills. So they do certainly a type of desktop drill, but also sometimes a practical aspect where patients come in as part of a drill so that the staff is aware that these things can happen. This is a disaster, may not necessarily be a natural disaster. But if this disaster should occur, we all are aware of the protocols for addressing this, how we operate, who we report to, what resources we'll need, and how to maintain and manage these patients that will come in. So certainly disaster drills need to be something that is common in every emergency department. This is after the disaster now. So in our response, our actions must be immediate, or immediate actions during and after the disaster. We're talking about things such as triaging and emergency care, search and rescue through emergency medical services, as well as activation of disaster plans. And I'm sure each healthcare organization would have developed a disaster plan. Now is to simply go through it, re-evaluate it. Is it robust? Is it something that is practical and feasible given the resources that you have? Or do we need to make changes to these disaster plans? And recovery. So this is restoration and return to normal function, such as rehabilitation of injured patients, rebuilding infrastructure, and mental health support. All of this may not necessarily be directed to the emergency departments, but this may be due to an institution at large. So are we rebuilding the pediatric ward? Was it that the infrastructure that was there was not suitable to manage these natural disasters? And so in our rebuilding phase, in our recovery phase, we're going to make a very robust ward that can manage that can withstand a natural disaster to that level or that degree again. And mental health support that I will continue to underscore. So reverse triaging is one way of assisting and helping in terms of preparedness prior to a natural disaster. And it's one way that I know that is publicized in the public setting. Before hurricanes, before large natural disasters, certainly in Jamaica, there are articles that are going out. The ministry is putting out that, where this is an emergency situation, discharge patients who can be discharged. Now, I'm sure there may be some people who are wondering, is this safe? How are we just sending home people that were previously admitted? So reverse triaging is exactly what that is. It's a management strategy that rapidly creates hospital surge capacity by identifying and preparing and discharging stable inpatients to make beds available for mass casualties. This was a study that was done that looked at reverse triaging as a whole. And it demonstrated that patients who were identified as safe to be discharged, meaning they had a low incidence of developing a major complication within the first 1 to 3 days of being discharged, were safe for discharge to provide space for these surge capacities that we may need following a natural disaster. So again, this was a study that was done in Ethiopia. It was a retrospective cross-sectional study that looked at reverse triaging and if it was indeed effective in expanding the capacity and the availability of beds prior to a natural disaster. And this study showed that reverse triaging could free up 10 to 30% of beds relatively quickly, with patients having a low incidence of major outcomes within 1 to 3 days after being discharged. Certainly, we have to keep in mind that after 3 days, some of these patients may represent because they may start developing complications. But at that time, our surge protocols or ED protocols would have already been in place and would have accounted for some of these patients who may represent after 3 days. Another concept to keep in mind is a surge staff model. Now, in our setting where we have workforce shortages and that sort of thing, this may be quite difficult, but it is something that we must keep in mind moving forward because things can improve. We can get full capacity staff at any point in time. And so we must operate in an optimal manner and keep these things in mind. So staff surge models are flexible staffing strategies used during disasters to manage increased patient volume and workforce shortages. The key principles involved are maintaining safe patient care with limited staff, in maximizing available workforce, and adapting to changing in demand and in acuity. Some of the models that are mentioned in a staff surge model include the just-in-time staffing, so rapidly mobilizing sessionals, essentially, to fill in gaps during surge periods when the demand is high and the in-house staffing is quite low. So it's engaging in sessionals to get on board to assist in surge, in trauma surge, infectious disease surge, or mental health surge, wherever the need lies. It also mentions an internal float pool, particularly in Type C hospitals where doctors tend to move from department to department based on the need. It certainly is a good idea to move physicians, nurses, allied healthcare workers to other areas that require a higher demand of staff if the area that they're currently working in is in low demand and we're considering that the hospital is in a surge period. It also mentioned tier staffing model as well as regional collaborative staffing. For example, Linstead Hospital is relatively close to Spanish Town Hospital. If Spanish Town Hospital is undergoing a trauma surge because there are violent attacks, there are gang wars, etc., then a collaborative effort could be to redirect some staff from the health centers, from the Linstead Hospital to assist in this acute surge period to lessen the burden on the in-house physicians, considering that all these institutions are under the same regional agency. So it'd be easy to transfer temporarily, of course, physicians to assist other hospitals in combating and managing these patients who come in during a trauma surge, for example, knowing that the mortality increases significantly for patients who present during a trauma surge. And we have seen that in post-Hurricane Melissa, where It wasn't official, but certainly several physicians from all over Jamaica, my consultants, I know for sure, they went in, several volunteers went down to assist the different hospitals that were severely affected by Hurricane Melissa. And so it may not be under the same region and it may be on a volunteer basis, but certainly to assist in managing the surge during that time, whether it be just seeing patients with chronic illnesses who may need a refill of prescriptions, or actually attending to patients from infectious disease surge or trauma surge. The last thing that I look at this evening are the phases of disaster and the emotional highs associated with a disaster. So the first phase is a heroic phase, which is the first 2 weeks following the passage of a hurricane or any other natural disaster. Everybody is a hero. We all want to help. We're all going down. We're all helping. We need to do what we can for our brothers and sisters who have been affected. Phase 2, which is the honeymoon phase, which is about 2 weeks to 2 to 3 months. There's lots of help still. There's some relief supplies are coming in even more. There are more resources that are directed to patients and people in need. In phase 3, however, which is the disillusionment phase, which is up to 3 months, up to 2 years, where essentially the freeness has dried up. Some promises are unfulfilled. The affected persons are very much left to fend for themselves, and harsh realities are there for them. And phase 4, reconstruction phase, which is 2 to 3 years. So in my estimation, we're still in phase 3, disillusionment phase. We need to keep that in mind. We need to keep that these patients that are affected and people that are affected by Hurricane Melissa are still having a hard time, are still having difficulty getting back on their feet, and still need our assistance. So as healthcare physicians, we need to manage our patients as best as we can, considering the infectious disease surges. In the trauma surges, we need to make use of a trauma surge index, as well as look at your hazard vulnerability analysis to see how best we can prevent some of these poor outcomes that we face following natural disasters. And these are my references. Thank you so much for listening.
Thank you, Dr. Roy, for that practical and very clinically relevant discussion. What was said will be applied in regards to our disaster preparedness and management. We have now come to the end of our grand round, and it is my hope that all the questions posed in the chat were acknowledged and answered. As we conclude this crucial session, not only on hurricane burden, but also on hurricane preparedness, I take this opportunity to do the vote of thanks. A sincere gratitude once more to our speakers, Doctors Williams and Roy, for an enlightening presentation. Your insights into patient care and the analysis of past storm or disease experiences have provided us with a clear roadmap for enhancing our resilience. To our leadership and planning committee, namely Professor Williams Johnson, our previous program director and current registrar of the Medical Council of Jamaica, to Dr. Simone French, our current program director, to Dr. Rhonda Hudson, or Accidents and Emergency Head of Department, to Dr. Romaine Edwards, or Supervising Consultant, and to all our individual supervisors. We thank you for your continued and proactive support in fostering a culture of preparedness, ensuring that we are not just reactive, but that we are ready before disaster strikes. I also thank our audiovisual team, Doctors Victorine, Cole, and Williamson, who were working behind the scenes to ensure that we had a session with little to no challenges. And to you, our audience, thank you for your participation and thank you for sticking with us. Your engagement and your thoughtful questions and comments remind us that disaster management is a team effort. We cannot prevent natural disasters, but we can manage the impact. Today's discussion has highlighted that our strength lies in pre-planning, in adapting, and in our ability to work together as one team. Let us take the lessons learned today to strengthen our operational resilience. And remember, as we provide care and mental support for our patients, let us remember to do the same for ourselves and for each other. We thank you all for your time, your service, and your continued commitment to patient care. Please stay safe, and this concludes our grand rounds. Do have a good rest of the evening. Thank you.